When we talk about HIV nowadays, unfortunately, many people here in the U.S. think it's not a problem anymore. It's a disease that's come and gone. That thanks to condoms and prophylactics and antiviral drugs, HIV is not an issue anymore. They're wrong. They're wrong because HIV is still present in our communities. Now, do we have the almost exponential outbreak numbers like we did in the late 80s, early half of the 90s? No. But it is still a steady state spread throughout the population. So, do we have the great outbreaks that we saw in San Francisco, New York City, Chicago? No, we don't have those. That was in the late 80s. Many people nowadays are mistaken, still think HIV, well, as long as I'm not a gay male, or as long as I am not, shooting up drugs, it's not a problem. Yes, when you look at incidence rates, infection rates, those that are going to be at the highest, with the highest rates of infection, gay men, okay, who practice unprotected sex or have unprotected sexual practices, and intravenous drug users who have a propensity for sharing needles. Other groups of people seem to think that now, because we have the antiviral drugs, HIV is not a problem. This is one that I find really disturbing nowadays. Because this isn't just from uneducated people. These are from college educated, even people with a science background are now diminishing the impact and the need to worry about HIV because we have HAART, HAART, not heart beating heart, but HAART, which is an antiviral drug cocktail. And because we have other antivirals that seem to work really well for HIV. And they work really well in the short term, okay? Short term here being relative means that before we had all these HIV antiviral drugs, being diagnosed HIV positive would mean you had a life sentence in less than 5 years. The first few generations of antivirals we had for HIV could extend that out to about 10, maybe 12 years. Current regimens of cocktails for HIV can extend that out to maybe 2.5 decades. And people think that's, well, you know what, that's a good life. I don't have to worry about it. Or people who are HIV infected don't have to worry about it. And as we're going to see in this lecture, no, as a clinician, even if you're not a clinician, you're just somebody out there in the real world, HIV is still something to worry about. Now, HIV, human immunodeficiency virus, is tied to 2 outcomes. We're going to see that at some point in time in the future. You get infected today, and in the future, 1, 2, if you're one of the few lucky ones, 3 decades from now, your viral load, being how many viruses are in your blood, is going to skyrocket. During that, 1, 2 decades, you're still going to have viruses in your blood, but it's going to be a low, steady state infection. It's going to be a low-level chronic infection. The virus is going to be hiding in your T cells, your CD4 T cells that are actually responsible for initiating your immune response and killing viral infected cells. So think about it. The perfect place for a virus to hide out. A long-lived cell that is responsible for your immune response to that virus. We see that it is an inverse proportion. Sometime in the future, when your viral load skyrockets, your T cell numbers are going to plummet. As your T cell numbers drop, that's what we monitor as the progression of your disease. When the T cell numbers drop below a certain point, where for all intents and purposes you pretty much don't have a functioning immune response, you have now entered into AIDS, acquired immunodeficiency syndrome. When you hit AIDS, as you are progressing towards it, you're going to see the accumulation of symptoms that we associate with a chronic disease: fatigue, diarrhea, weight loss. As the infection spreads throughout your body and your metabolism starts to become affected, you're also going to notice in neurological changes. In a clinical setting, when a patient presents with the onset of AIDS, you'll also begin to see that they will begin acquiring opportunistic infections or different types of cancer that a quote-unquote healthy person just would not get. As we're going to see in this lecture, that's going to be fungus growing on the brain, different feline leukemia virus. Yeah, feline, a cat virus, will lead to cancer in the AIDS patients. As this progresses, you're going to see that the body mass will begin to waste as the overall, their physical metabolism begins to deteriorate. The fatigue, the diarrhea is going to lead to decreased intake of food, of nourishment. They're going to be losing lots of nutrients, lots of calories. They're going to be losing because, well, their gastrointestinal tract is not going to be functioning correctly. Their large intestine is suddenly going to become colonized with non-enteric bacteria. Their mouth is going to be colonized with bacteria that we would not generally consider to be non-oral environment. Everything starts to change, and it's going to lead to poor nutrient absorption. The cells, the epithelial lining of their gastrointestinal tract itself, is slowly going to begin to deteriorate, to fall apart. So when you look at this progression of the disease, to be HIV positive means that you are making antibodies to the HIV virus itself, to the proteins that make up the capsid, to proteins that make up the spikes. Your viral load, or I'm sorry, not yours, I keep saying yours, not you, since you're going to be a clinician, the patient that you'll be seeing, their viral load within the first 2 weeks of being exposed, their viral load will skyrocket. That's what you see in the green here. The titers within their blood, how many actually virus particles you can isolate from their blood, will go up. And then after a few weeks, it will begin to diminish. And over the next few months, it will diminish. And as you see that through the decade or so, it will be just barely detectable. The antibody, the orange line, it's going to take a few weeks to set in. But once it does, they will be a steady state throughout the rest of their life. Notice to the far left there, that 2-ish week period before they are HIV positive, but they have a high viral titer in their bloodstream. That could be the problem. Somebody does something, the patient did something they shouldn't have, whatever it was, and it caused them to be exposed. Okay? They immediately go get tested. Oh, I'm HIV negative, no problem. They continue whatever it was they were doing, they do it again and again. And over that first few weeks, the titer's going up, and their ability to spread the virus also goes up. Notice to the far right, where the green line depicting their viral titer starts to go up, and that purple line, which is their CD4 T cells in their bloodstream, that for a healthy individual is going to be greater than 500. 500 cells per microliter. And just to put it in a reference you can understand, an average drop of water is 100 microliters. So that means so 1 microliter is 100th of a drop of water. So a drop of blood should have about 50,000 white CD4 T cells. Okay, not white blood cells, because that's all of the monocytes, macrophages, T cells, B cells, all of those. No, this is just specifically CD4 T cells. 500,000, or I'm sorry, did my math wrong. 50,000 per drop of blood. But as you follow that line, that purple line, as their disease progresses, however many years, decades that may be, there will come a time when it's going to go from slowly decreasing, and then they're going to hit a tipping point where it's going to start dropping off. Then it's going to hit that point, 200, less than 200 cells per microliter. That's the threshold that we generally make the determination that the patient is now at the beginning stages, the onset of AIDS. And when you look at an AIDS patient, their immune system, for all intents and purposes, is gone. Yes, you could still detect CD4 T cells there. Yes, there are still monocytes and neutrophils present, but they are not functioning correctly. Because of all the other symptoms, the diarrhea, the malabsorption, all of this is affecting their overall metabolism. Their immunoresponse is degrading quickly. So you start looking through some of these illnesses. Cryptococcus neoformans. We talked about that in a previous lecture. HIV encephalopathy. Toxoplasmosis of the brain. Candidiasis of the trachea. Candida albicans. Okay, a yeast will overgrow their mouth, their sinuses, their nasopharynx, their trachea, and their lungs. When you look at pictures, if you go and you Google pictures of candidiasis in an AIDS patient, their mouths will literally look not quite foamy, but really thick mucousy foam where the yeast has overgrown. You begin looking and you'll start to see that other diseases that their bodies would normally keep in check start to overwhelm. They've ever been exposed to herpes, any of the herpes, herpes simplex 1, 2, chicken pox, whatever. They will begin to be overwhelmed by these chronic ulcers that are going to start to appear not only on their skin like a cold sore would, but it's going to begin to spread down to their throat, into their trachea, the gastrointestinal tract, and even into their lungs. Talked HIV back during the viruses chapter. Okay, it's a lentivirus. It's an RNA virus. Contains its own reverse transcriptase. Commonly, you'll see it as the acronym RT. The enzyme reverse transcriptase will take the single-strand RNA viral genome and will make DNA copies. Turns out our cells will not recognize RNA in the nucleus. Actually, having RNA in the nucleus long term without all the markers that makes it says it's mRNA will make our cells immediately destroy it. So reverse transcriptase takes the RNA, makes DNA, and then our own cells will take the viral DNA, that copy, and start making copies of it, treating it as though it's just your DNA. This is why we also refer to them as retroviruses. If the DNA gets into a virus particle and it goes and infects another cell, it's not going to do anything. It has to be RNA. RNA enters into the cell. Reverse transcriptase makes DNA copies. The host machinery makes RNA copies from that DNA, just as if it was making messenger RNA. And then that gets packaged and one virus goes in, hundreds if not thousands come out. What we do know is that sometimes those retroviruses will insert into a human genome, insert somewhere into the chromosomes. Perfect place to hide. Well, here's the problem. Where does it insert? It's random. Sometimes that randomness means it's going to insert into genes that are responsible for maintaining the cell, maintaining the cell's mitosis control, the regulation of mitosis. So it gets in, messes with, the cyclins and the CDKs and all the different proteins that regulate checkpoint control. And next thing you know, you have a cancerous cell. Each of those cancerous cells contain a copy of the HIV genome. It's an enveloped virus. So one goes in, hundreds or thousands come out, and each of those is going to tear off a piece of the CD4 T cells' cytoplasmic membrane. So one goes in, those hundreds, those thousands come out slowly over time. And as they're coming out, as you see in the picture here, there's going to be viral proteins, those spikes that were embedded in the infected cell cytoplasmic membrane and will now become part of the envelope. We would call these spikes they're proteins, they're made of multiple proteins, but we refer to them as GP120. GP120 will interact. It co-opts, come on, there you go, there it is, the CCR5 receptor. CCR5 and the CD4 T cell receptor. By co-opting, and here when I say co-opt, I mean truly hijack. We do not have receptors just for HIV. No, somewhere along the thousands and thousands of years, or the tens of thousands of years of human evolution, human, Homo sapien. Then you go back to our, ancestors, Neanderthal, all of those. They were also exposed to these different viruses. But you follow those along, and somewhere along the way, a virus mutated and came up with a shape that allowed it to hijack CCR5, hijack CD4. So you'll see nowadays they're talking about the CCR5 as a great target because CCR5, if it's mutated, slightly different shape, still functions, but a slightly different shape, means that HIV cannot utilize it. So you'll see nowadays they're examining people that are a CCR5 mutant. And for whatever reason, these people, even with lifestyle choices that may increase their exposure chances, just do not become infected with HIV. What do we know happens during an HIV infection? Well, for the patient, somehow they're going to be exposed to HIV, okay? And it's not just on their skin, okay? The dead epidermis of the back of your hand. No, it's going to have to be a mucous membrane. Mouth, vagina, different parts on the penis, the rectum, okay? If it is going to be through skin, it's going to have to be skin that is abraded, okay? That allows the virus to penetrate down below the outer layers of epidermis down to the dermis. However it gets there, infects a living cell. One goes in, hundreds, thousands come out, and then there's going to be a dendritic cell. Dendritic cells are cells that are on patrol, looking for anything there. You, not you. They go, they pick it up, they digest it down, and then they go to the nearest lymph node. Whether it's the lymph nodes under your jaw, your armpits, your groin, around in, your small and large intestines, wherever. They go and they start showing whatever it was they digested, and they start showing it to CD or T cells, CD4, CD8, monocytes, macrophages, B cells, whoever, whatever, until somebody recognizes it. Now, like I said in an earlier slide, the virus hijacks the receptors, forces its own uptake. Once in, you're going to see this progression, this early progression where the RNA that was in the virus is going to be copied as DNA, that reverse transcriptase, and then that DNA, that viral DNA, is going to be trafficked, carried to the host cell nucleus. There, it's going to be treated as just DNA. Any DNA in the nucleus is treated as host. Things are going to be copied. Genes are going to be read and mRNA made. There's a reason why I talked, thinking of this lecture, talked sexual practices and the transfer of blood, intravenous drug use. We now test all blood products that are going to be used for a patient. If you donate blood, they will test the blood. If you donate plasma, they test you to make sure, things like that. They didn't always do this. Late 80s, early 90s, when this was becoming a more and more prevalent problem, especially mid-late 80s, they like to sit there and say, well, they didn't test, they didn't want to know. Well, first off, they didn't have a test that was foolproof. They were using a test that would sometimes give a false positive. It was a test for another infection that cross-reacted for antibodies to HIV. So it wouldn't always tell you yes, no, wouldn't always give a correct answer. They quickly, over the years, developed a test that, again, based on antibodies. Are you presenting antibodies, which, as we saw a few slides ago, means you have progressed so far into the infection. When it comes to transmission, sharing of blood products, sexual intercourse, anal, vaginal, oral is reduced because all the acidity and the digestive enzymes of the mouth, but it's still there. Sharing of needles, sharing of blood products that haven't been tested. Vertical transmission is an issue. HIV virus, the virions can cross the placenta. And if they don't cross the placenta, got to remember, travel through the birth canal is a dirty, messy, bloody process. Even if you were to have sex with somebody who is HIV positive, even if you did share a needle, it is not 100%, the probability is not 100% you will get an infection yourself. It turns out HIV, the virus itself, is actually not very sturdy. Doesn't survive outside of the host. Doesn't, if stuff dries, the blood, the semen, whatever, once that stuff dries, the virus dies. The virus is, destroyed. I don't want to say died because it's not a living thing. It becomes irreparably damaged. So it turns out there also has to be a really high dose level. Okay, think about your mouth. Your mouth is quite acidic. There's a lot going on there. Same with the vagina. The environment of the vagina will, damage a lot of the viruses, not all of them. So there's going to have to be a high titer or high number being passed person to person for there to be an infection that can be established in the recipient. They have been shown that all blood products and most secretions can have viruses in them, but so far there has been no studies to be able to prove that saliva can transmit the virus. I say no studies as of yet because as we get better and better with DNA technologies and testing for the presence of DNA or RNAs, you never know. They may be able to show, hey, look, it's there, but it's in such low numbers, blah, blah, blah. We generally associate blood, semen, vaginal secretions. Semen and vaginal secretions not only are going to have, blood products, are not only going to have, the normal secretions, say like semen, going to have sperm and products of the prostate and stuff. But we've also found that there can be white blood cells and that are passed along, and in those white blood cells are going to be viruses. They've also been able to show that viruses are low-level detectable, but detectable in urine, tears, sweat. Again, I know I just said last slide, you can't transfer it with saliva, but there are, counterindications that the viruses can be detected, but because of the environment the saliva is in, the envelope gets irreparably damaged, so it can't fuse. No uptake. But you have to, take that with a grain of salt. So now we are still trying to play catch up with another generation. HIV numbers over the past decade have been creeping back up. Late 90s and the early 2000s, we were able to get those numbers to level off, maybe even decrease. New case numbers decreasing in certain areas of the country. Well, we're starting to see that those numbers are ticking back up. So we need to, as clinicians, as educators, to start getting that back out there. When it comes to HIV infection and AIDS, the 80s where we saw the big outbreak. 35 million people worldwide. Best estimates, about that same number were infected. But they didn't progress very quickly into AIDS. 1.2 million people here in the US. To put that into context, they are, 200,000 COVID as of now? Somewhere around there, 250. So 1.2 million in the first few years of the AIDS epidemic. And the AIDS epidemic hit only certain populations, whereas COVID hitting everyone. So just to kind of put you things in perspective. People generally associate HIV with the gay populations. Male, anal intercourse as the transmission method du jour. Some areas of the world, it's actually unprotected heterosexual intercourse. Heterosexual intercourse, lots of partners, can lead to greater chances for the spread of the disease. Southeast Asia is a great example. Certain countries in Southeast Asia are a little more turning a blind eye to prostitution. One prostitute gets infected. That prostitute has unprotected sex with dozens, if not hundreds of men, per week, per month, whatever. Does everybody who has sex with that prostitute get infected? No. But there's going to be a certain percentage that will. You look at Africa. Africa is going to be the same thing. One person gets infected, they will pass it on to a handful of others who will then pass it and pass it and pass it. Here in the US, we see that there's a disproportionate spread of the disease, spread of the infections. The African American population here in the US has a disproportionate percentage of infections. Why? Don't know. There's lots of people want to point to systemic racism, to, well, there's just not, as much education of things like that. We'll also have to take into account certain cultural things. Teenage boys are going to be a little more reticent to use condoms during sexual intercourse. So they're going to be spreading, diseases, not just HIV, but other STDs. When we see a new mother-to-be is HIV positive, They will begin an anti-HIV drug regimen that will hopefully reduce the vertical spread of the virus to the fetus. Now we have to be careful. Some of the drugs that can be taken can have slight toxic effects to an adult. Well, turns out those slightly toxic effects to the liver and the kidney will be increased in a fetal developing liver, kidney. So the same drugs that a 45-year-old male who's HIV positive would take may not be the same ones you want a 24-year-old pregnant woman to be taking. They have shown that the vertical transmission, about a 1 in 3 chance, okay? 30% chance of spread from mother to developing fetus. When it comes to diagnosis, our #1 diagnostic tool, which is what here in the US we base all of this on, is the presence or absence of antibodies to HIV. Now this is different in other parts of the world. Okay, in parts of Europe, they are clinically testing HIV vaccines. So just on the bare what they're doing, they're infecting with a genetically altered HIV virus or a chemically denatured HIV virus, depending upon which of the vaccines you're talking about. Either one are going to elicit an antibody response. So anybody who gets the vaccine will automatically be positive for the HIV virus. So that's part of the reason why you'll see some people are a bit reticent here in the US to start using the vaccines, testing the vaccines, because our whole clinical establishment is based on presence, absence, antibodies. Europe is trying to segue, as they're using these vaccines, away from that and doing an antibody titer. And as we saw in the earlier slide, when you're talking titers and HIV and antibody, you know, where you test, at what point you test, you know, you could have high antibody titers but low viral load. So you could get a false negative that, oh no, they don't have HIV, they're just HIV positive because of the vaccine. So that's something we're going to have to work out and try to figure out. Because of that timing issue, here in the US, if you donate blood or you think you may have been exposed, they draw blood, and they test you after a certain number of weeks post-exposure. You know, yes, you've tested positive. Well, they're not automatically going to hand you, you know, a prescription, say, here, start taking all these antivirals for the rest of your life. No, they're then going to do a follow-up. Okay, can we detect a viral load in your blood? And they're going to do that multiple times. Because you could have had an exposure event, but you didn't get an actual infection. Or it could have been a false positive. So what are we trying to teach people again, especially teenagers, young adults? You know, avoid sexual contact. If you're in a committed relationship and your partner is HIV positive, then you have to use barrier method during sex. Okay, whether that's a condom, fit on a man, vaginal condoms, oral dams, whatever. For all intents and purposes, avoid IV drugs. Okay, if for whatever reason, your choices in life, you cannot avoid IV drugs, do not share needles. That's why in some cities they do the needle exchange program. They have an issue with hepatitis rates and HIV rates. Comes right down to it, there's no cure for HIV. Okay, once you get it, you've got it. Basically, what we're now doing is trying to develop drugs that are going to slow down the spread. Okay, see if we can't keep that point from, keep as many CD4 T cells there as possible and decrease the viral load, keep that as low as possible for as long as possible. Whatever treatment's going to be done needs to be done as quickly as possible after diagnosis. Longer you wait, the more it'll spread, the higher the titers, the faster your CD4 T cells will begin to become depleted. Because once you hit AIDS, that less than 200 CD4 cells per microliter, well, there's no coming back from that. Once you hit that point, the patients are going to basically they're going to decrease quickly. You're looking at lifespan there, weeks, maybe a few months at best. Once they've hit that point where you now just consider them to be an AIDS patient. So, there are numerous antivirals. Some work better than others, and it's going to be dependent upon the patient. So you'll see that a patient will start off with one cocktail, and then over time, as titers change, CD4 numbers may decrease. They may change up the cocktail, add a little of this, take this out, and see which will work better. So there's no all HIV positive patients get this and only this. There is some art to it.